Bless. All right. So we did the minor introductory stuff, but we'll continue from there. So welcome again to fall semester this time around. So for those of you that are new, we have our mission statement here, just kind of creating an educational platform for everybody that is interested in exploring wilderness and emergency medicine through all of its various avenues, and just showcasing how wide and diverse of a sphere that this really can take as a whole, and hopefully creating some international community in the process. For this year, just wanted a really quick drop. This is our executive board. This is slide 1 of 2 on our wonderful executive board. And this is slide 2 of 2 of our executive board for this year. All wonderful people. And we've managed to put together this awesome speaker schedule for you guys with that November slot to be filled in hopefully soon, things in the works. But we'll come back for all of our future lectures and enjoy learning with us. So, and as always, follow us on Twitter and Instagram. You can get the most up-to-date things. And if you haven't already, please join our mailing list. We do these bi-weekly throughout the semester, and we also kind of send out other wilderness opportunities as well as conferences and other stuff. I'll give you about 10 seconds more to get that QR code. In the meantime, I'm just going to drabble on, make it seem like we're filling the space. All right, you've got the QR code. And to introduce our speaker for today's today's series, I'm sorry, did I cut you off getting the QR code, Dr. Lou?
Yeah, I was a little slow on the draw. Do you mind? So
yeah.
Yeah, sorry about that. Okay, thanks.
Absolutely. So our first speaker is Dr. Val Lou. She is an emergency medicine physician at the University of Rochester. She completed her medical degree, UC San Diego, residency, master's in public health, and an international EM fellowship at University of Rochester. She's also completed the DIM in 2019 with the WMS, and a former Denali Park Ranger, certified yoga instructor, mother of 2, soon to be 3. Ooh, nice. And avid maritime enthusiast, special interest in climate change, human health, currently holds a position of assistant program director for the University of Rochester EM residency, and teaches wilderness medicine to medical students and residents. And with that, I will hand it over to Dr. Lou to give her talk today. And let me unshare. All right.
Well, thank you for that introduction. And I am quite pleased to see this crowd of people listening to a wilderness medicine lecture on like a Labor Day weekend on a Monday evening. So I'm very, very flattered. So actually something I didn't do that I wonder if, just to be kosher, you like require financial disclosures or anything like that, or other organizations that I'm part of. So I am, just so everyone knows, I am paid by the University of Rochester to teach emergency medicine and wilderness medicine, as well as occasionally by CU Denver, and to teach wilderness medicine and AWLS. I actually teach with one of the lecturers that's coming up next for water treatment, Todd Miner. So you guys are going to have quite a treat with him. And I'm also on staff at Kinetic Adventures, which is a wilderness medicine CME. So all that aside now. So today we're going to talk about pregnancy and the wilderness athlete. And this is something near and dear to my heart because as a wilderness enthusiast, I consider myself an amateur athlete and who's gone through pregnancy twice, and I'm currently on my 3rd pregnancy at 35 weeks. It's something that's been a big part of my life. So who knows who this is here? You can't see her face, but the setting might look familiar. So this is Beth Rodden. Oh, did someone get it in the chat? Yes, good job, Ellen Smith. This is Beth Rodden, and she has done a bunch of ascents in Yosemite. And this is her, I think at 5 or 6 weeks pregnant. You can see she's doing some trad climbing. She's got some sports straws here. She's tied in. And so this is like who I usually think about when I'm feeling aspirational as a wilderness athlete. But I think to really understand this topic, we do also need to just think about the female wilderness athlete in general. So this is Beth Rodden when she's not pregnant, climbing super hard. And so we'll go into this a little bit too. I looked in the archives of Go WME and I didn't see anything on it. So hopefully there isn't too much redundancy with what you guys already know. So I have some goals for us on today's talk. And if you guys want to add anything to this as well, like any knowledge you're burning to know about pregnancy in the wilderness athlete, please let me know in the chat or just speak up. I'm very casual. So I'd like you guys to, at the end of this talk, be able to describe some differences in female physiology versus male, to describe changes in pregnancy physiology, and be able to list at least 3 benefits of wilderness activity and exercise during pregnancy, as well as 3 hazards. This is not a super comprehensive talk because we only have 1 hour, but I'm also hoping that you guys will be able to discuss sport-specific recommendations for pregnancy. And then at the end, we're going to go through and kind of transition from the wilderness medicine to the emergency medicine realm, and to be able to demonstrate understanding of some key principles of trauma care for a pregnant athlete. Does that sound good? See nods? I love it. Okay. So yeah, if you have any questions, anything needs clarification, I have the chat screen up as well, but also just feel free to chime in. Okay, so this is what we're going to go through. So some trends in just kind of female participation in the wilderness realm. Traditionally, it's been a very male-dominated field, but as of 2017, which 5 years ago now, ancient history, 51% of outdoor consumers were women. So I bet that number is even higher now. And we've gone from a very traditionally male demographic to people who look like this. So this is Heather Anderson, and she's a triple crowner, meaning that she's done the PCT, ACT, and the John Muir Trail, I think 3 times in 3 years or something insane like that. And she holds the time record for fastest self-supported completion of the PCT. So this is what the future of wilderness medicine now encompasses. But the people who are in charge and making gear, making policies, making recommendations for care of these participants are still largely male. So only 12% of outdoor companies that make gear have female CEOs, and women still only make up 37% of the National Park Service, which is, if you ever go to a national park, those are the people in the pickle suits and the funny hats that, kind of direct you where to find the bathroom and also how to discover nature. So the other interesting thing is that it's not a huge part of what most people, even people who are wilderness enthusiasts, understand about people who are accomplishing things and bagging summits and making these big accomplishments in wilderness medicine. So there was a survey put out recently to a group of mountaineers, and only 13% of them knew the name of the first woman up at Mount Everest. So everyone knows Sir Edmund Hillary, right? But anyone know the first woman who summited Mount Everest? And I had to look this up too because I didn't know it, but it was Junko Tabe, and it was in May 16th, 1975. So it's not new news, but I found that interesting. Okay, so some general things about female physiology. So these are generalities. Obviously, there's going to be individual differences and exceptions to this, but in general, when you're taking the population of women as a whole, they have, they're smaller, they're shorter, with smaller waists and proportionally larger pelvis, hips, and breasts. So this is important for gear. If there's any of you gearheads out there, you know how important the perfect fit is, not just for clothing, but for a mountain bike that fits you correctly, or for just anything that requires fine tuning and balance, like the right pair of skis. So having women-specific gear is really important for high-level performance. They also have smaller volume feet. And this is important if you're going into high altitude areas where it's really cold. It's really important to have well-fitting boots. I actually had a lot of difficulty tracking down really good technical mountaineering and ice boots for my feet. I'm like an average size woman. I'm about 5'4", size 8, but even a men's size 8, which was the best quality boot I could find, like my foot was kind of swimming in it because my foot was narrower than the average male foot. We have cooler extremities. We have more type 1 muscle fiber, meaning that most women have more muscle fibers that are good at endurance. And also they're like the slow twitch or red muscle fibers. There's a great ability to mobilize fat during exercise. And there's also varying hormone levels depending on where you are in your menstrual cycle. So when you take this to pregnancy, so this, I want you guys to bear with me because I know this physiology stuff is a lot, but it's really setting the stage for understanding what's coming next. Okay, so just bear with me here. So physiologic changes. Cardiovascular, you have a huge increase in cardiac output when you're pregnant with a large increase in blood volume. So this is kind of an interesting statistic. What percent do you think your blood plasma volume increases by when you're pregnant? Yeah, it's like 40 to 50%. So this happens largely, well done. This happens largely in the second trimester. So there's a larger circulating blood volume and you get kind of like a relative anemia, but the expansion in blood volume is basically a protection against peripartum hemorrhage. You also have decreased peripheral vascular resistance and increased resting heart rate. And when you are in a supine position, so when a pregnant woman is lying flat on her back, she has decreased cardiac output. And this is really important if you're thinking about, search and rescue scenarios. If you are transporting in a litter someone who's pregnant, if you lay a largely gravid woman on her back, the compression that happens with her uterus on top of her inferior vena cava will decrease preload to her heart. And so she'll have decreased cardiac output, both to herself and also to her fetus. So very important if you're dealing with someone who's had some trauma and might be hypotensive. That's important to know. And there's also, if you just simply tilt them about 30 degrees on their left side, so left lateral decubitus, that offsets the uterus enough that you can have some improvement in cardiac output despite them being on their back. So you can see a lot of these changes are happening during the second trimester. So big changes happen around 12 weeks of pregnancy. And that 12-week mark is actually going to be pretty important for things in gear, things in recognizing when trauma and placental abruption really becomes risky as well. Other physiologic changes, breathing. So progesterone actually causes an increase in your tidal volume and respiratory drive. And so women, starting from actually very early on in pregnancy, are in a respiratory alkalosis. So I'm actually going to take this moment to tell like a personal story. So I was doing my diploma in mountain medicine a few years ago, and I was sitting in a lecture on respiratory physiology. I won't name the lecturer and call them out, but they were speaking about, these changes that happen in males and females and different scenarios, and passing around a pulse oximeter. So this was, we were at Breckenridge. So I think we're about like at 9,000 feet. So most people, their O2 sat was about 92, 93%. That was kind of the average going around. And by the time the pulse ox came to me, I noticed that I was still satting 97, 98%, which is kind of weird. And I kind of tested it on all my fingers and asked my friends. And I finally raised my hand and I said, excuse me, everyone else is satting 92, 93%. Why am I satting 98% right now? And the lecturer just looked at me dead in the eyes, was like, you're pregnant, which I thought was very, very bold. But he ended up being right. I was early enough in the pregnancy that I did not know I was pregnant yet. But due to the increased progesterone levels, I had developed a relative respiratory alkalosis that actually allowed me to hyperventilate enough to bring up my O2 sat to like 97, 98%, which was, and I think he read my demographic right. That was, but it was still very bold. And I I was impressed and also a little bit embarrassed, but it ended up being okay. So that was an interesting story. The stuff is real. Beginning at 20 weeks, the elevation of the diaphragm reduces your functional residual capacity. So you're able to take, you have to take shallower breaths, and then your oxygen consumption conversely increases by 20%. So you have increased demand, but somewhat decreased supply. So you can imagine if you have someone who, developed a traumatic pneumothorax, I mean, you have less time to take action there, right? Pregnancy is a procoagulant state. Really important to know if there is someone you're advising who is traveling abroad, maybe taking like a really long plane ride, they're going to be more prone to getting DVTs. Also, if anyone has been around a pregnant woman, you've probably heard them complain about GERD, and that's a physiologic change due to decreased lower esophageal sphincter tone as well as increased intra-abdominal pressure. Okay, so this is like a key thing I want you guys to pay attention to, is this picture. So this picture is really important because it shows you where in the female body the uterus is during certain months of pregnancy. So you can see here for the first 12 weeks, really, the uterus is a pelvic organ, right? So you have this whole bony cage of your pelvis, which is super robust, protecting the uterus. So even if you have like a fall, some sort of traumatic event, honestly, unless you fractured your pelvis, the fetus and the uterus are probably fine. If you did fracture your pelvis, I mean, you had a high mechanism injury and you should be really suspicious for intrauterine injury. So 12 weeks, still a pelvic organ protected by the bony cage of the uterus. By the time you get to like 20, 24 weeks, it's really at the level of the umbilicus. And that's important to know because that's kind of like the borderline for viability outside the mother's body. So if you're thinking about, actions you need to take for someone, you can think about this female or this fetus might be eligible to have like a C-section, an emergent C-section if there's uncontrollable hemorrhage. Finally, uterine blood flow is not autoregulated the way blood flow to some of your other organs is. So that means that the fetus is incredibly sensitive to changes in blood pressure. So if the mother is hypertensive, the fetus is experiencing elevated blood pressure. If the mother is hypotensive, same deal. So that's something to keep in mind as well. Okay, can I stretch your arms out, take some wiggles after all that physiology, just let that sink in. And I just want to talk about some general things about caring for women in the wilderness. Actually, one of the other hats I wear is as an advisor and an expedition medic for the British Exploration Society. And they take care of a lot of young women. They're like, they do Knowles type excursions for young people in Great Britain. It's been on hold because of COVID, but historically that's what they do. And caring for women has another set of issues you have to deal with. So women are more prone to UTIs, so you have to have the right antibiotics for that. If someone has abdominal pain, a very important branch point is, are they pregnant or are they not pregnant? So having point of care pregnancy tests as part of your medical kit is important. Also for treatment, if someone is pregnant and it's not desired, or they're having complications, or they had sexual activity that was unprotected, having the morning after pill is important, having things to help symptomatically like Zofran and Tylenol is important. Something that I think has kind of faded in the limelight, but is still a big issue in tropical countries is Zika virus. So if you're doing an expedition somewhere where there are mosquitoes and mosquito-borne illness, and you have women of childbearing age, being able to counsel them on the risks of Zika virus and microcephaly is something that you may not think about right off the bat, but you should. And finally, live immunizations can often be contraindicated for people who are pregnant. So if you're traveling abroad, you have like 50 million different vaccines you need to get before you go. You need to keep that in mind and think about which ones are live immunizations and should be considered more carefully. And of course, your abdominal pain differential is different if you have additional intra-abdominal organs like ovaries and a uterus. So practicalities, and I just love that there's a book called How to Shit in the Woods. The nice thing is that women shit in the woods the same way that boys do. So, you know, that the butthole is the same, but, pun intended, the urethra is different in females, right? And this actually really came to the forefront for me when I went back and I was doing some mountaineering and glacier stuff on Rainier, because I hadn't done it for a few years and I forgot all about this, but it's kind of hard to pee if you're in a climbing harness, you're roped up for glacier travel, and you have like 5 layers of clothing on. You know, the urethra is not protruding in front and center the way it is in a male. So these kind of funny looking devices, I think there's several brands, are basically funnels with a little tube on them. I think one of them is called the Shiwi or the Sheepy. They're actually incredibly useful. They're not just these like weird niche accessories. I would highly recommend anyone who is a climber and does multi-pitch and like needs to be in a harness for a long period of time to familiarize themselves with how to use these. Yeah, I think it's a necessity. Also, hygiene is important. So having a dedicated pee rag that you tie to the outside of your pack, and having a Nalgene bottle that is labeled so you're not confusing it with yellow Gatorade would be appreciated by your fellow travel members. So I usually draw like a little skull and crossbones on it or something so people know. Also, how to have your period in the woods. I know a lot of my peers actually will time their oral contraceptives and skip the placebo week if they know they're going to be on an expedition, or they have a Mirena or other hormone-containing IUD so that they don't get their period. But some people just have their period, and that is very workable as well. The important thing to know is that no, bears will not come after you if you are menstruating, but bears will come after used menstrual products. So if you're menstruating in the woods, know that you have to store like used tampons and stuff like that, where you would store like things in a bear can. So just make sure that you know proper disposal. Something that you might not all be familiar with are things like these menstrual cups. There's various brands. The Diva cup is a very popular one, and these are great because they can be left in for like 12 hours. So if you're on, you know, a long multi-pitch route, you don't want to have to worry about changing your tampon, you know, familiarize yourself with how to use the Diva cup or one of these menstrual cups. So there is some initial learning curve and how to place them correctly so they don't leak. And then knowing that they need to be rinsed out with water and you need hand sanitizer before and after insertion is important. That said, if you do want to go the disposable route, there's all sorts of interesting first aid uses for menstrual pads and tampons. And actually Susan Spano, who I believe is still with UC Fresno, has a really great talk on improvised uses for tampons. So, you know, ask Susan Spano, but these can be repurposed for other things as well. Okay, so the pregnant athlete, risks versus rewards. All right, now we're getting into the meat of it. So the governing body for obstetric care is the American College of Obstetrics and Gynecologists. And if you look in the most recent edition of Wilderness Medicine by Auerbach, so who here is like a really big wilderness nerd and owns like the 2-volume 7th edition version of Wilderness Medicine by Auerbach? Yeah, it's actually great. I kind of love it. It's very verbose. But I think it's a good text. However, it is not up to date on things related to obstetrical care. Nice. Yes, tears running down my face as well. It's like expensive and enormous. It's like, but it's really fun to look at the pictures and for a casual read. So what they have for obstetrical care is actually out of date. So what it has are old recommendations from ACOG saying that the maternal heart rate has to be less than 140 beats per minute during exercise. That's ridiculous. Like anytime I exercise now, my heart rate's definitely above 140. Strenuous activity for less than 15 minutes, also ridiculous if you're doing any sort of prolonged wilderness activity. avoiding your core temperature, getting higher than 100.4. I get hot when I exercise, even though I sweat a lot. That's also not doable. And then running and other endurance sports should be done with care because they divert blood from the uterus, which is not actually evidence-based. So these things are not legit anymore, which is great, because these recommendations really focus on like the costs of doing these activities as a pregnant woman, right? They're like a little bit overly cautious. They're not evidence-based. And modern day pregnancy doesn't look like that. You know, you have people doing major rock climbing routes. You have people like Bethany Hamilton, who's not only surfing pregnant, but with one arm and ripping on the waves harder than most of us ever could. There is one of the clerkship directors for the University of Vermont, Sarah Schlein. I know she's done major backcountry skiing when she's been like 38 weeks pregnant. And Serena Williams, just in the news, she won the Australian Open while she was pregnant. So, I mean, these women are not stopping exercise with a heart rate more than 140, right? That's just not practical. Well, the nice thing is there are updated recommendations from ACOG that focus more on some of the benefits of exercise, still weighing in the costs, but these are much more reasonable. And I think these are getting us closer to how we can advise pregnant wilderness medicine athletes to carry forward with their activities and their pregnancies. So this is what I would go by. So it's actually several pages long, but I highlighted some key take-home messages to kind of shorten it. So basically, physical activity and exercise are associated with minimal risks. That's good. But, you know, it's like your mileage may vary, right? Women are all different. And unfortunately, a large proportion of American patients have a lot of chronic disease and a lot of risk factors for their pregnancies, may have high risk pregnancies. So a thorough clinical evaluation should be conducted before recommending a certain exercise regimen. Okay, I think that's good practical knowledge. Common sense. So women with uncomplicated pregnancies should be encouraged to engage in aerobic and strength conditioning exercises before, during, and after pregnancy. And concerns that regular physical activity during pregnancy may cause miscarriage, poor fetal growth, premature delivery have not been substantiated with uncomplicated pregnancies. So this is all very reassuring. Also, exposure from hot tubs and saunas and fever, especially in the first trimester, although associated with an increased risk of neural tube defects, increasing your core temperature with exercise does not have the same effects. And there's no association between exercise and neural tube defects. And this is a big thing because I definitely know some female marathon and ultra marathon runners who were counseled by their OBs previously that they should avoid heavy exercise because of this. And it turns out it's not true. And this is also like pulled from the ACOG paper. So these are the benefits of exercise for the pregnant woman. You have higher incidence of vaginal delivery, lower incidence of gestational weight gain, gestational diabetes, things like eclampsia, HELLP syndrome, less preterm birth, fewer cesarean sections, and a lower incidence of lower birth weight, which is like intrauterine growth restriction. These are all good things. Also, there's increased fitness for the work of labor and delivery. And symptomatically for a pregnant woman, I mean, you feel better when you exercise. Decreased likelihood of varicose veins, faster return to pre-pregnancy fitness, improved sleep, reduced back pain, reduced constipation. I find the women who are doing these physical feats of fitness incredibly inspiring. So, you know, there's women who are running world championships in the 800s. This is, I think, Alyssa Montano, when they are in their third trimester of pregnancy. And I think a woman who was in her second trimester summited Rainier. So people are going out there and getting it. Some of you guys might be asking, okay, but what about the baby? You know, there's all these benefits for the mom. And I do want to emphasize that it is also safe for the fetus. So there's minimum increases in fetal heart rate that's prolonged after exercise. birth weight differences are minimal to none, no increase in fetal growth restriction, and strenuous exercise is well tolerated by women and fetuses in active and inactive pregnant women. All right, so that was a lot of information. So I'm gonna ask you guys a few questions that I didn't directly tell you, but I want you guys to kind of think about now, armed with the information that you got. So true or false, and these are admittedly kind of tricky and hard. Exercise should be stopped if there's decreased fetal activity. So actually, I like the uncertainty because people are waffling there. And no one wants to say whether it's true or false. So it's kind of, well, it depends. True? Question mark? Kind of. So in general, so you might have heard if you've done an OB rotation as a medical student, you know, when you're in your second and third trimester, women should be doing kick counts and making sure there's good fetal activity. If, you know, after exercise is completed, you don't feel fetal movement, that is concerning. But during exercise, it is extremely, extremely common to have decreased fetal activity because it's kind of like you're being rocked to sleep. So if you go for a run or you're on a bike ride, it's going to be very common for the fetus to just fall asleep. They're not going to be moving. And it doesn't mean that they're dead. So you shouldn't stop fetal activity or exercise if there's decreased fetal activity. But it can be a warning sign if, you know, 30 minutes, an hour after exercise, you're feeling decreased fetal activity still, that can be an issue. But it's not like a contraindication. In the past, ACOG used to say, if you don't feel fetal movement, you should stop exercising. So then that meant nobody exercised because like the fetus would be basically rocked to sleep by rhythmic physical activity. All right, one more. So true or false, exercise should be stopped if there are uterine contractions. I like how everyone has a different thinking face. I know. It's pretty, everyone's always like, So this is another tricky one. Depends. Yeah, depends is always a great answer. So yeah, depends. So uterine contractions, again, are extremely common during exercise. Braxton Hicks contractions can be stronger, especially with subsequent pregnancies. So a woman who's carrying her second, third, fourth, fifth child is going to have stronger, more frequent uterine contractions that are not dangerous. If you're having, if you or your patient who's pregnant is having very strong uterine contractions that are painful or uncomfortable, it probably means that they need to hydrate more. So remember that increase in plasma volume that happens with pregnancy, it takes a lot of liquid to keep that up. So they should probably hydrate more. They should make sure they're not becoming excessively hyperthermic. Maybe take a little break if they're having bothersome, painful, prolonged uterine contractions, but it does not mean that they need to stop exercise. That said, if you're having uterine contractions with leakage of amniotic fluid or vaginal bleeding, I mean, that is a really big warning sign. You know, if you're going into labor, you should probably cut your ultramarathon short and seek a hospital. All right. So that's all well and good, but you know, the realm of you folks here isn't in a gym or on a treadmill. It's outside, really doing activities in the wilderness. So either you guys or the clients you're advising may be doing things like scuba diving or rock climbing or mountaineering or mountain biking, right? So I think it's important to know some sport-specific recommendations for these populations who are doing these activities and are pregnant or may become pregnant. So I'm going to go through kind of these 4-ish sports that do have recommendations in place for them. Okay, first one is scuba diving. So who here is a diver? I love diving. So scuba diving is wonderful. It is exhilarating. A lot of people recreationally dive. But this is actually one of the activities in which pregnancy is kind of a contraindication. So scuba diving, most authorities, so you look at both the American College of Obstetricians and Gynecologists, the CDC, PADI, which is a dive organization, consider pregnancy a contraindication to diving. There's really good reasons for that, actually. So the fetal placental circulation does not protect you, the fetus, from nitrogen bubble formation. So decompression illness, which is very common, can actually have teratogenic effects on the fetus, both with like limb deformities and other issues. And just some of the hormonal effects of pregnancy can make diving very uncomfortable and difficult or even dangerous. So little known by people who aren't pregnant, but when you're pregnant, you actually have increased mucus production and engorgement of mucous membranes in your nose and oropharynx. And if anyone's tried to dive with like plugged ears before or stuffy nose, I mean, that's just a recipe for tympanic membrane rupture if you can't equalize your eustachian tubes. So that can make breathing very difficult and equalization very difficult. Also, you have changes in your buoyancy due to fat deposition. You're more prone to decompression illness due to higher fat content of your body. And you also have exaggeration in some of the dyspnea that you're experiencing, and that can be very panic inducing. And panic when you're underwater can be life-threatening. So like one of the first rules you learn when you're diving is to not hold your breath when you're ascending. But if you're hyperventilating, that can make you freak out. You freak out and you ascend without breathing, or you ascend too fast. It can cause a whole range of issues. So that actually makes me not want to scuba dive when I'm pregnant, despite how much fun it is. Some good things to know, though, is that a woman who finds out she was pregnant during the time she was diving is advised to not terminate the pregnancy. So there are certain drugs that are extremely teratogenic, where if you are known to take this medication, the advice is to terminate the pregnancy because of, you're basically guaranteed to have, fetal defects, right? Actually, in this day and age, you are lucky if you live in a state where you're allowed to terminate pregnancy. But advice for scuba diving is that you don't have to terminate the pregnancy, but it is dangerous. And there's also case reports of women who have been able to have normal pregnancies despite continued diving. So if you have someone who's really gung-ho, they absolutely insist on diving, the recommendation is to not dive below 60 feet because you have increased risk of decompression illness, and to only remain underwater for half the recommended dive table times to, again, lessen your risk of decompression illness. So I feel like at least you can still give those women some advice to lessen their risks. If you're really into this stuff, there is a great review of diving and pregnancy that it's kind of too long to go through all the recommendations, but if this is your jam, I would recommend reading it. Okay, what about rock climbing? So there is not specific dedicated evidence from governing bodies on rock climbing and pregnancy, but I feel like this is one where understanding of pregnant physiology and common sense can get you really far. So in your first trimester, there is very low likelihood of risk of trauma to the fetus. So I continued lead climbing and used a regular harness because I still fit in it. And I'd say that that's reasonable. It would be probably not the time to start rock climbing if you've never rock climbed before. But if this is something that is part of your regular activity, it's very reasonable. Lots of women continue climbing in a regular seat harness when they're in their first trimester. In your second and third trimester, if you guys remember the picture of the uterus kind of rising to the umbilical level or higher, it's not great to be climbing at that time period because of equipment issues, as well as risk of trauma to the uterus and a risk of placental abruption. So basically tearing of the placenta away from the uterus. So there's certain risks, and I would kind of categorize them as things from equipment, like harness pressure, things from rock or object falling that could cause direct blunt trauma to the abdomen, or leader falls. So if you guys are rock climbers, like if you're doing a sport or trad climbing route and you are leading the route and climbing above your last piece of protection, you can generate, like, I don't remember my math, but like 6 or 8 kilonewtons of force, which is a lot with a leader fall, right? So that's not great for the placenta. Placenta is not meant to handle that. So I think some potential solutions are wearing a full body harness. So Mad Rock actually makes a full body harness, and the difference is the master point, rather than being at your waist, is actually up here at your chest. So it avoids putting any pressure on the abdomen. It's actually doable to sport climb and lead or trad climb in it, as long as you're not leading. There's gear loops to hang stuff. It is cumbersome, and sometimes having your figure of 8 knot right up here in your neck is not the most comfortable thing if you're doing long climbs, but it's doable. Also, just common sense, climbing in areas where there's solid rock. If you're doing a lot of outdoor climbing, following rather than leading to avoid those leader falls. If you're bouldering, really doing low routes or traversing low to the ground, so you're not experiencing a lot of jarring if you take like a 20-foot fall, if you're climbing at the buttermilks or something, and then focusing on less technical climbs. So there is some change with tendon strength and just musculoskeletal issues. And I kind of had to swallow my pride a little bit on this one. I was actually just at like a rock gym and climbing something that I usually climb with not a lot of difficulty, but it was still pretty technical. And on a crimp hold, I ended up tearing my AC2 pulley on my hand because of changes, like hormonal changes that happen. So that put me out of commission, and it made me super sad. And you just have to tell your clients, you can continue climbing, but there are changes in your body. Don't let your pride run away with you. Listen to your body. So if, doing crimper holds or certain really technical routes that require you high step your foot up to your head, like that might not be doable for you right now. And you might want to wait a few months until you can do it when you're not pregnant. Okay, so I was trying to find literature on this, and the closest thing I could find was an occupational report on people who do a lot of standing, lifting, and climbing for their occupation. And so what I took away from this is it said very clearly, climbing does not affect fetal growth, but long work days are detrimental to the fetus. So you can take that to your employers and say, I can't work long hours, but I need to go climbing more, because that's really what's going to be better for myself and my pregnancy. So, the evidence is there. So this category, I put a picture of a mountain biker, but I think a lot of this also applies to people who are skiing, surfing, horseback riding, anything where there's a potential for crashing and significant falls. So doing these activities on a very low level is pretty safe. There's like Olympic dressage riders, a type of horseback riding, who have competed while pregnant. There's definitely people who surf and ski. Again, not the time to start these activities if you've never done them before, but for a normal, healthy pregnancy, for someone who's familiar with these activities, there's very little risk during the first trimester. When you get to the second and third trimesters, you have changes in weight, your center of gravity, and there's also a lot of ligamentous laxity that happens that can make these dangerous. So something, I'm going to tell a lot of personal anecdotes, so I'm not going to embarrass anyone else I know, but I was paddleboarding. So I used to do a lot of paddleboarding when I lived in San Diego, but now I live in Rochester, New York, which is pretty landlocked. I don't do a ton of it, but I went out paddleboarding and I did not realize how much my weight had shifted. And I immediately fell pretty hard on my ass. So just be aware that, those changes will happen. And if you're continuing to do it throughout pregnancy, you're very familiar, that's fine. But know that there are real risks. If you take a hard fall during one of these sports, you want access to a tertiary care hospital. You know, the best thing to do is to not put yourself in that position in the first place if you're worried about it or you don't feel confident or it's a sketchy route. But having access to emergency care is really important. Finally, mountaineering. So this is a hot topic, and I think also like a prime area for research if any of you guys are really research minded. So this is a recommendation from ACOG, which I feel like is pretty lame because it basically cuts out any sort of activity at altitude or even skiing. Like you can't go skiing like anywhere like in Colorado, I feel like, if you're going by these recommendations. So if you live at sea level, you can kind of go up to 6,000 feet. So that means you can't ski at Breckenridge, right? And women who reside at higher altitudes may be able to exercise safely at altitudes higher than 6,000 feet. So that's actually not helpful. But fortunately, there are some recommendations that are evidence-based from UIAA, which is the international governing body for mountaineers. And they had a whole series of meetings and put together a consensus paper about pregnant women traveling to high altitude. So there's a whole bunch of information here. I'm going to again hit the important points, but if this is something that you if you're an advisor or an expedition medic for mountaineering, you should know these. And I would just read this paper. So for your first trimester, short stays at altitude up to 2,500 meters without heavy exercise are fine. If you are planning to exercise, plan to allow a few days to acclimatize. But if you're a woman at risk for spontaneous abortion, you should avoid altitude exposure altogether during your first trimester. Unfortunately, spontaneous abortions are really common anyways in the first trimester. But I think this is a pretty conservative recommendation just to acknowledge that. If you have preeclampsia, placental eruption, risk for intrauterine growth restriction, you shouldn't go to high altitude even for short stays. If you have carried your pregnancy to the second or third trimester, short stays at high altitude expose little risk to the pregnancy during the second half of pregnancy, which is good news. So your contraindications to going to altitude are basically like any pregnancy complications. So preeclampsia, chronic hypertension, impaired placental function, intrauterine growth restriction, and anything that basically makes it difficult for your body to deliver oxygen to the fetus anyways. So if you have cardiac or pulmonary disease, you have anemia, you have smoking, that's all going to make it much harder for the uterus and the fetus to receive the oxygen that it needs to grow. So acclimatization is going to be a huge pain if you're following these recommendations. So they recommend 2 to 3 days of acclimatization for moderate exercise. If you're doing strenuous exercise, to plan at least 2 weeks for full acclimatization. I don't know about you guys, but I have a job, I have a life that basically like precludes doing any sort of mountaineering activity for following these guidelines. But I think if you're trying to help someone have a safe pregnancy and this is something that they want to know, you have to be pretty upfront with them that these are the recommendations. So I'm not going to go over this too much. Some important things to know about acute mountain sickness in pregnancy. The incidence of acute mountain sickness doesn't differ between pregnant and non-pregnant women. But if you have someone who habitually takes Diamox or acetazolamide to acclimatize for high altitude, it is contraindicated during the first trimester and also not recommended in the latter part of pregnancy due to risk for neonatal jaundice, which puts you at risk for kernicterus. So they may not be able to rely on using that drug to help them with their symptoms. So that's really important to know. That said, if a woman has acute mountain sickness, you need to weigh the risks and the benefits. So if someone had symptoms of HACE, high altitude cerebral edema, I'd probably still give them dexamethasone because of the risk of that. As always, descent and oxygen are your preferred treatment, right? Just get to a lower altitude. But you can still consider those drugs if there's life-threatening illness or something that's very debilitating on an individual basis. Okay. And actually this section got a little truncated, but just know that there are a lot of musculoskeletal injuries that can happen in pregnancy that are not as prevalent in the usual population. So pubic symphysis separation is a thing, or osteitis pubis. So the front part of the pelvis, which is usually pretty rigid and has like a cartilaginous connection, becomes very soft, and you can have physical separation of the pubic symphysis during pregnancy, which is really painful. So some women, because of this, can't walk upstairs because their pelvis is so lax. So if you have a woman that's starting to develop those symptoms, you know, maybe horseback riding or mountain biking should be put on hold for them. People are also prone to more ligamentous laxity, yeah, cross-country skiing, that's right. So like the pulley tendon injury I told you about that I sustained, or you know, if they're already prone to ankle sprains and knee injuries, that's something you need to counsel them on. And neuropathies are also more common. So like at least like 50 to 80% of pregnant women experience sciatica type symptoms and low back and pelvic girdle pain. So kind of beyond the scope of the talk here, but note that there are ways to manage this, but that they can be very debilitating for the pregnant athlete. Finally, pregnant women can sustain significant non-traumatic fractures by just being pregnant. And I find this amazing that, you know, like half our population may at some point go through these processes for pregnancy and childbirth, but pregnant women can sustain sacral stress fractures and femoral neck fractures just from being pregnant. And actually, something like almost 50% of women who had a prolonged or complicated delivery process ended up having some sort of pelvic fracture, which is incredible. Your pelvis just broke. And vertebral compression fractures and metatarsal stress fractures are also more common. So just keeping that in mind when you're advising people with worsening pain. Okay, so we only have a little chunk of time left. So I want to ask, is it okay if I go 5 minutes over, or I can also just cut it short?
I think if you need the 5 minutes, I think we can go the extra 5 minutes. Obviously, anybody is free to leave. It is your time. We know it's Labor Day. Yeah, you know what?
I will be offended.
Yeah, we'll go the 5.
So now I want to just switch gears from wilderness medicine to some emergency medicine stuff. Because I'm an emergency medicine doc, that's what puts food on my table, and I'm actually going to a shift right after this. So help me switch gears and get my clinical hat on. So we're going to do a case. So you have a 31-year-old female presenting with a fall. She was climbing at Red Rocks when she took a whipper, so she took a lead fall. She had no immediate injury, but now complains of abdominal pain and vaginal bleeding. And you were at a tertiary care hospital. Okay. So letting that case kind of sink in, what are your immediate thoughts about this case? No wrong answers here. Do a pregnancy test. Yes. So you guys hopefully were primed by the title of this talk. This is a pregnant wilderness athlete talk. Yes, is she pregnant, right? So just so you guys know, female patients seeking treatment in the ED have a pregnancy rate of about 10%. And 11% of women with abdominal pain or vaginal bleeding who have a positive pregnancy test, even when they stated there is no chance they are pregnant. Do a pregnancy test, right? So it turns out this lady's pregnant. This is important to know because trauma is the most common cause of non-obstetrical death. That means not peri-delivery. Unfortunately, domestic violence is very common. It's increased in pregnancy. Motor vehicle accidents are probably the most common cause of fetal and maternal death due to trauma and falls. So it's not likely that you'll see a lot of trauma from wilderness medicine, but I think a lot of the principles that you use to deal with trauma in pregnancy from domestic violence or MVAs can help you if you have a patient like this who has like a wilderness medicine or wilderness activity related injury. Okay, so going back to our patient, she took a lead fall. She's, having some abdominal pain and vaginal bleeding. So she has a heart rate of 130, a blood pressure of 95/60, a respiratory rate of 33, an O2 sat of 95%, and her physical exam shows a tender abdomen with, you can basically palpate a large firm mass up to the level of her umbilicus. What are your thoughts about that? So about what trimester of pregnancy do you think she's in? Hold up fingers. 2, yeah. So her second trimester, she may have a viable fetus in there. And actually, any one of these signs is not like a huge red flag, but they should be red flags for you because she's pregnant, and also taken as a whole, you are going to start to worry about this woman. She is tachycardic, she's relatively hypotensive, she's tachypnic, and that O2 sat of 95%. You remember your respiratory physiology in the pregnant population, that's actually an inflection point, right? Her the oxygen tension curve is not favorable for her fetus right now. Get this lady on a non-rebreather, right? You should start thinking about resuscitative measures for her. And I would call OB to bedside, right? If shit hits the fan, pardon my French, you want them there. She may need an emergency section. So I'm just going to go through some very basic resuscitative steps. And this is the stuff to remember. Resuscitate the mother to resuscitate the baby. You want to position her in left lateral decubitus because being supine decreases your cardiac output. Remember the uterus squishing the IVC. Call OB early, and ultrasound is a really important tool. That 20-week thing that we talked about, remember the picture of the pregnant belly with the uterus at different levels? This is actually important because if you get to a point where you have maternal instability, doing an emergency C-section can actually be life-saving for both the mother and the fetus. So, you don't have regulated autoregulation of blood flow in the uterus. It can be a source of huge amounts of bleeding. So having a C-section, removing that source of bleeding may be important to save the mother's life and the baby's life. So the breathing thing, again, maternal oxygen saturation should be kept over 95%. So be aggressive with that. And if you're placing chest tubes, place a chest tube in the chest cavity, not in the abdomen. So for those of you who this is part of your practice, it's kind of drilled into your brain, chest tube between the 4th and 5th intercostal space. But if you have a giant gravid uterus occupying your abdomen and your abdominal contents are squishing your diaphragm all the way up here, if you went at the 4th and 5th intercostal space, you would be, if you're on the right side, you're in their liver. If you're on the left side, you'd be in their spleen, which is not where you want to be with your chest tube. So place a higher chest tube. Remember your positioning. If you can't tilt your patient at 30 degrees, you can actually designate either like a tech or a nurse or someone to just pull the uterus off to the left, and that manual displacement as well can pull the uterus off the IVC and improve the patient's blood pressure and circulation. So the big complication is placental abruption. And what I have to say about that is most people who are going to have a significant abruption do have abdominal pain and cramping, vaginal bleeding. But if you had someone with significant enough mechanism, even if they're asymptomatic, I would have OB place that patient on fetal monitoring and also do an ultrasound to look for bleeding. Okay, so the mechanism is very important. This 31-year-old lady, she'd for certain get placed on fetal monitoring. Okay, so some important take-home points on this. So trauma in pregnancy, Lord help you if you have to deal with one of these cases. They're usually very nerve-wracking. Consider pregnant physiology. Remember, resuscitate the mom to resuscitate the baby. 95% is your action point to put on oxygen. Displace that uterus off the vena cava. 12 weeks is kind of your safe spot for the uterus, where before that it's a pelvic organ and protected by the pelvis. And use your ultrasound if that's part of your scope of practice. And then finally, I didn't really say this earlier, but if you have a blood type for a woman who's Rh negative, you need to give immune prophylaxis with RhoGAM if they have bleeding. And if you think that this patient is going to have a C-section in the near future or is at risk of it, to give glucocorticoids to help with maturation of the fetal respiratory system. Okay. So future directions, and I want to pitch this to you guys, as you look like, the future faces of wilderness medicine. There's a lot that needs to be done for this population. This is a very, very ripe area for research. Even if you're not like, a down in the trenches biochemistry type person, there needs to be more epidemiological studies done on pregnancy in the wilderness. So great opportunity for research projects. There needs to be more clinical care guidelines written. So the WMS actually doesn't really have anything definitive on pregnancy in wilderness athletes. So, you can, if that's part of what you do, you're part of the WMS, part of your sphere of influence, advocate for that. Demand good outdoor gear for women and women who are pregnant. And then just thinking about the next step after pregnancy, creating welcoming spaces for women who are nursing and for infants in wilderness spaces. So you can make the world friendlier for them when they come back. So I want to thank you guys, especially because I went over a scooch, and for joining me on this Labor Day evening. I really enjoyed talking to you guys, and I am open for any questions if there's time for questions.
Yeah, so at this point, anybody that has any questions, first of all, thank you, Dr. Lou, for that talk. I know I learned quite a bit, and I'm sure everybody else did as well. And if anybody has any questions, feel free to drop them in the chat, or feel free to unmute at this point and ask your questions here.
So something I can do if you have a venue to share it is I can, make these slides open source as well, if anyone wanted to look at them. So just let me know if there's a place I can put a link or something.
Yeah, I'd like to have access to that if you wouldn't mind. So if there's a source.
Absolutely. I think we can probably publish the slides on our website. So I'll get the link from you afterwards and we can make sure to get that done. And yeah, the lectures should be available. We upload all of our lectures onto both our website and I think our YouTube now within a couple days to weeks. So maybe not immediate turnaround, but it'll be there at some point.